Thank you for the nice introduction, and I will build on Sue's talk earlier so we can see more evidence of how we can assess network modulation associated with real-time fMRI neurofeedback in clinical population. And I wanted to also just quickly comment, there's something about sitting in this room with a lot of people who make history of SPM and learning about that history in the historical building that feels a little meta, and thank you for the opportunity to let me so vetted. And a lot of what we do with neurofeedback, I actually say, is build on the foundational knowledge that we gain from analysis that were enabled by toolbox like SPM or SPM inspired toolboxes like Common and Art. So Sue has talked about the mental health crisis. I'm not gonna delve into the details, but it's a costly problem. It affects a lot of people, and especially in children and adolescents. And unfortunately, gold standard treatments are not effective for all. So in my talk, I will reiterate the neuromechanisms that we can target, and then go into more detail for this novel intervention that's a real-time fMRI neurofeedback. And I will go into details for two specific applications to depression and schizophrenia, and just highlight some ongoing work and future directions at the end. So as Sue mentioned, deep optimal network is the network that we think typically involved in planning for the future, creative thinking, reminiscing about the past, but in a disordered brain could be implicated in worrying about the future, delusional thinking, and rumination. There is a lot of theory and meta-analytic evidence showing how it's implicated in disorders such as depression. And its interaction with the central executive network is also a very canonical example of anticorrelation. And there is some evidence showing that there may be some top-down regulation of the central executive network of the default mode. And so with that, I'm going to go into the first application, which is a proof of concept study for affective disorders. As was shown before, we have participants in this sort of real-time fMRI neurofeedback setup. They lie in the scanner as usual. We get them to use a strategy which is based on mindfulness meditation in order to modulate their brain activity. And specifically, what we're doing as experimenters is receiving these images of their brain, bold images, and analyzing in real time, extracting the DMN and CN time courses. And then we can use that to display back to the participant whether they're really able to move the activity or activations in those two networks. And there is usually a preferred direction. In this case, we ask the participants to try to move the ball up, which reflects a downregulation of the default network and an upregulation of the central executive network, and vice versa. And we feed this back to the participants via the projector. And this is obviously done in the real time, so participants can incorporate that information quickly on their next trial. And this is personalized as we try to localize each person's own default mode and central executive networks. And this is network-based, so we're not trying to modulate a single region. We can modulate the activation in a whole ensemble of regions. And I didn't put it here, but as Sue said, it gives participants agency, gives them a lot of patients feel very powerless about their conditions. And when they're able to move the ball, anecdotally, we hear them talk about how amazing it is that they understand now they are able to make that change within themselves without external stimulation. And here I wanted to show you a video, hope it plays, yeah, of what it looks like in the experiment. So on the left side, you see the participant's view. On the right side, you see the researcher's view. And there's some instructions. It'll go through that. And once it starts, you'll see on the right, within the first 30 seconds or so, we build a baseline model of where the participants' default mode and central executive network activations are like. And then past the first 30 seconds, the ball will start moving. So this is when the experiment starts. First, they're relaxing, and you see the vertical line marking the passage of time. In the beginning, you don't see any. Oh, there we go. So I'm not sure if it's easy to see. In the magenta line is default mode network, and the green line is central executive network. And in the beginning, they're not doing anything. It's a kind of flat line. But after a while, they're going to see the ball and the circles, and this is their cue to start practicing mindfulness. And what you can see is this participant is able to drive up their central executive network more. As you can see, the green line kind of is on top of the magenta, and that translates to the ball moving up, and that's a cue to the participant that they're doing the right thing. And after the ball goes up for a couple of seconds, the circle fills up and it comes back to the middle. So it continues going like this for about 2 minutes. And we have made this adaptive so that between subsequent runs of this paradigm, we can make it more difficult for people who are doing really well. You actually see people whose ball shoots up all the time. Okay, so for this particular proof of concept study, we had 9 participants who had a lifetime history of depression or anxiety, and 3 of them had a diagnosis at the time of this experiment. And it's really a pretty simple design. We have baseline scales and questionnaires, and post neurofeedback questionnaires, and the neurofeedback run in the scanner. And we do collect resting state data before and after neurofeedback. So this enables us to do a few different analysis. Oh, sorry, I should quick note. I think people here might be more interested in how we do the personalization. So we run the ICA on that neurofeedback resting state, and take the components that match best the typical canonical default mode and central executive network templates. And those are the ones that we then warp to the brain that's in the scanner right now to extract the signals from. So yeah, as I said, this design allows us to run a few different types of analysis. First, we can look at baseline symptom to brain correlation. And in this case, we replicate the finding where within default mode connectivity correlates with symptoms. So this is a nice validation. And this is also important for us to know in this particular context, because we want to know if this target can also be modulated with neurofeedback, which we then can see by contrasting the pre-neurofeedback and post-neurofeedback resting state. And what we saw was that there is a reduction. So I forgot to show the subgenual ACC seed here. There is a reduction in connectivity from the subgenual ACC to canonical default nodes. And amazingly, this is it's 9 subjects. So you might say, is this a good effect? But we found it promising that this reduction was observed in each individual participant and doesn't seem to be driven by the diagnosis. And we can also look at the correlation between functional connectivity change pre-post cursor and the behavioral change pre-post. So in this study, we didn't have symptom data, but we did look at a validation of state mindfulness, which showed that people who were able to reduce the connectivity in the default mode network showed a corresponding increase in mindfulness, which is a good validation for why we think this is working, which is the mindfulness strategy. And that was 9 subjects, and we're now running a bigger trial with 90 subjects in collaboration with Columbia University. And in this project, we're doing the same neurofeedback, collecting baseline data, as well as a 30-day follow-up to see how long this effect lasts. Okay, so now going to the second application, which aims to reduce auditory hallucinations in schizophrenia. So in this particular application, the auditory cortices are important because auditory there's a lot of evidence of altered neurobiology of the auditory cortices in auditory hallucinations. And specifically for us, it has been hypothesized that the aberrantly high communication between the default mode node of MPFC with auditory core disease may be underlying this symptom. So what we did here is same setup, participants goes in the scanner, and we get real-time data, but instead of looking at the contrast between default mode and central executive networks, we are taking the activity in a personalized superior temporal gyrus node that preferentially responds to self versus other voice, and that's something we get from a localizer. This is not a continuous design, and in this one, we have blocks where we ask participants to either listen to their own voices or try to ignore all sounds, including other voice as well as scanner sound. And they get a thermometer feedback, which they want to see a green instead of red, and I'll show a bit more. We had 25 participants in this study of patients with schizophrenia or schizoaffective disorder, and they all had moderate or severe medication-resistant auditory hallucinations, and the hallucinations are assessed through this SIRAT scale. Importantly, in this study, we were able to randomly assign participants to receive either real or sham neurofeedback. So the real feedback, as I said, is based on their auditory cortex signal. And the sham feedback is from the motor cortex, which we think has nothing much to do with hallucinations. So similar to before, we have this sort of design where we have baseline plus post-neurofeedback assessments and resting state as well, before and after. So here I just wanted to show that this is a block design for the neurofeedback training. And if participants are correctly using mindfulness to ignore sounds, then they show green downregulation. If they're correctly attending to the voice, they show upregulation here. And if they're doing the wrong thing, then they'll see the red. And we have some evidence of neurofeedback performance where participants were able to reduce their superior temporal gyrus activation, specifically for the real group in black, from pre to post. And while there's no interaction effect showing a preferential reduction in auditory hallucinations in the real group, there is a general reduction for both groups, and we think maybe just the mere practice of mindfulness without the real feedback can help too. So in terms of the results, again, we can look at baseline symptom correlation, and in this case, when we look at the connectivity between MPFC to PCC within the default mode network, that connectivity correlates positively with baseline symptom. We were able to also look at something called the transfer effect. So at the beginning and at the end of the neurofeedback training, we have a run where participants see the balls, but they don't move. So what this tells us is how much a participant is able to take the learning they had from the neurofeedback, where they saw the feedback, to a context where they are supposed to just practice, but they don't see that feedback. And when we looked at the transfer data, we saw that participants, and looking at task-dependent default mode connectivity, we saw that participants showed a reduction in MPFC to PCC connectivity in the real group compared to the sham group. And again, we can look at pre-post resting state change. And in this case, we observed a reduction in the real group of MPFC to STG connectivity. And if you remember, I was talking about before about how this hyperconnectivity between these two regions might be driving auditory hallucinations. So this is a good thing to see. And again, we saw this effect in each individual from the real group compared to the sham, which is in the opposite direction. Within the default mode itself, we try to run a small volume corrected analysis just to see if there is any reduction in MPFC to PCC connectivity, especially since that did correlate with symptoms at baseline. And it was there once I matched the analysis to the PCC. Quickly going through this. And another thing we did with this sample was to look at the whether we can really look at what participants benefited more from this neurofeedback based on their baseline characteristics. And what we found was that if we correlated baseline default connectivity with the rest of the brain, those participants who had more within default connectivity showed more reduction in symptoms. And those participants with more anti-correlation between the default mode and the DLPFC also showed more reduction. And this was, if I put both in the model, the anti-correlation is the only one that uniquely predicted change. So I can talk more about why I think that is, but I wanted to go to the main takeaways. With real-time neurofeedback, we can do a few different types of analysis, such as looking at baseline correlation, looking at task-dependent functional connectivity change, resting state functional connectivity change, and we can correlate to get the mechanism. We can correlate the changing functional connectivity and the change in symptoms. And lastly, we can look at what kind of baseline features predict change. And we have an ongoing study that's longitudinal with 4 neurofeedback sessions to see if there is any dosage effect. And other ongoing work includes using this in at-risk individuals and application to borderline personality disorder, and as you mentioned, closed loop modulation. Give this and just say thank you to all our collaborators and to my mentor, Sue. Thank you.